One sec.
Going live is going live. So yes.
Yeah.
Hello, everyone.
Ansha.
Yeah. Hello, everyone. Welcome to this webinar by SIMSA. SIMSA, as we all know, is the South Indian Medical Association, which was made by a group of passionate young medical students, and it is recognized by by the Indian government, which is basically the most fast-growing association. So I welcome everybody to this webinar where we have our guest as Dr. Yasir Hanif, who is a young medical doctor practicing in Kettering General Hospital in the UK. And here he is with his in-depth study on the neck of the femur. So I have a little story for you people. And the anthropologist Margaret Mead, she was asked by her students like what was the first sign of civilization, and the students were expecting the answer to be maybe the fish hooks or the clay pots or the grinding stones. But indeed, the student was surprised by his answer, and that was when the anthropologist said it was by the femur bone, that is the thigh bone, which is the longest bone in our body, and the healing of it. Okay, the civilization basically began when what happens is when in the animal kingdom, when a person has a broken leg, he cannot survive, he cannot go to the water, he cannot go to the food, he'll basically be the prey to the beast. Okay, so what happens when there is healing? That means that is an evidence that somebody took care of it, somebody was there to heal it, somebody was taking care of it, and hence this is how the civilization started. So here we have Dr. Hanif. We will be talking about how the delicate neck of femur and the post-injury. So you may please start.
Thank you, Insha. Hello, everyone. I'm Dr. Yasir. I work as a junior grade doctor in the Kettering General Hospital. So, as Insha was saying nicely, that the evidence of civilization has been seen in the past when they have found the evidence of like treated neck of femur fracture. So it's interesting, and I think we believe I will still carry on the civilization by treating the neck of femur fracture. For all you guys who are undergrads, who are still studying maybe first year, second year of medical school, and the people who are graduates already or pursuing postgrad studies, I will try to make it very simple for all those people who are undergrads particularly, because why this neck of femur fracture is so important. All you guys must be thinking that there are so many joints. We have got 206 bones. We have so many articulations in the body. We have fixed joint. We have mobile joints. So why neck of femur fracture is so important for us? Well, the answer is simple. We people and doctors tend to concentrate on such things which are important, particularly. See, we will think about the basic necessities of life rather than thinking about something which is luxury for us. So the same thing comes with the joints when we think about joints. So neck of femur is very important because it's something which is essential. And when we talk about essential, we think about the morbidity and the mortality associated with this joint. So as we orthopedicians have seen that the joints that are most susceptible and are relatable to the morbidity and mortality of the people, well, hip joint, neck of femur fracture is the most important one. And particularly in elderly population who are fragile, who have weak immunity, whose body is giving up on them, who have comorbidities. So all those people can improve or can be saved or salvaged if we treat neck of femur fracture in time. So the purpose of this presentation is, being as an orthopedic doctor in Kettering General Hospital, we see like countless number of patients in emergency department, in our orthopedics wards, in clinics, in fracture clinics every day. And UK is predominantly an elderly population. So a simple fall, simple things can make things worse when we talk about neck of femur fracture. So the purpose of this presentation, as I was mentioning, is the thing that I did a research about how care is delivered to all those people who are elderly, who come in contact with the emergency department, and how quickly they are transferred to the orthopedics ward and how quickly they are operated. It's very important. Once you diagnose neck or femur fracture, it's important to operate within 72 hours because uh, if we delay it unnecessarily, it can increase the mortality because there will be loss of blood in the hip joint. It's a big joint and there will be loss of blood in it, and which will result in shock and other things, and coma and death, obviously. And morbidity. There will be decrease in the quality of life if we delay the treatment or surgery of the neck or femur fracture. So there will be decrease in mobility, and those people will have more needs in day-to-day activities. They will need more help, which will cause burden to government, to the people associated with it. We have to deal with all those things. So the best thing is to make sure that once a patient who is elderly, who has fallen down, who has sustained neck or femur fracture, comes to A&E, that's emergency department, they are immediately diagnosed with an X-ray CT scan. They are taken from there to the orthopedics ward where they are maybe given a resuscitation fluids or many other things, analgesia. We have taken their blood pressure, checked their vitals, sugar levels, and other things quickly, and make sure they go to theater immediately. So I did a small research about a group of 100 patients, and we have been doing this research in three small sects. Like one sect was from month of May to July, then we give a break, and then we did again from September to November. So we compared those two sects with all together and see, is the care, is it delivered to all the patients in time, how other things that are very important in the treatment of neck or femur fracture, whether they are given in time. And we compared those two sects and saw differences. So let's start with the slide, the presentations that I have made. Yes, I would like to thank my mentees, Lina, Pooja, Insha, Dina. They've been really helpful for all this presentation. So yeah, they are my mentees now. I think I have some problems with the presentation. Please bear with me. Okay, so here it is. Let's go with the anatomy of neck or femur and the hip joint itself. As you can see from here, the pelvis bones, iliac crust and everything, you guys know much better than me. Then we have femur. So the proportion, the distal, the proximal portion of the femur has neck. It has ball and socket joint like acetabulum and the ball. Then it has neck. This neck's very important, femoral neck. That's where the fractures usually occur, and we see breaks. We see displacements. The fracture will be undisplaced. It will stay in the line. It's like, if it's the joint, it will break, but it will not get displaced. Sometimes it will be fracture displacement, like it will be broken and it will be like displaced. So yeah. Sometimes it can be intertrochanteric fractures, like this is greater trochanter. Nothing, it's just a name. At the end, it's just a bony tuberosity or just a bony elevation in the one at the base of the neck of the femur. And this is lesser trochanter. So a line joining from lesser trochanter to greater trochanter will be called a line of intertrochanteric line. Sometimes the fracture can happen here, and it can again be displaced or undisplaced. So all those fractures can occur in the at the base of the neck or femur, or it can be intertrochanteric. All those are considered as neck or femur fractures. It is joint's very important, as I was telling you, because it's a big joint. It's a weight-bearing joint, so it's very important for the body. So as I was mentioning about the research we did at the Kettering General Hospital, in two sects, as I was saying, we might say as a group A, group B at different times in 3 months time interval and 3 months time interval again. Then we started comparing the data about how we can improve the quality of care to the patients how quickly we can take those patients. So whenever we do a research, we have some standards against which we'll do the research. Okay, you are just doing a research. It doesn't mean that you are just going blank or you're just going blindly. You are just collecting data. But there should be some reason what you're looking for, what exactly you're doing, and what you are aiming from the collection of data or interpretation of data. So we have taken two standards against which we are trying to compare our data and see how efficient our department, how efficient hospital works, how efficient the patients are getting treated in our hospital. So as you can see, the first standard was like how quickly the patients are transferred from emergency department to orthopedics ward. So we have a time frame according to British Association of Orthopedics. It's called BAO in short, BOA. So they have given the timelines that from the start, from the point of contact to the ward shift should be within 4 hours. It's very important and it's strictly taken care. But yeah, there are delays sometimes. Maybe emergency department is overburdened. There are a lot of patients, severe sick patients. The trauma orthopedics doctors, sometimes they are busy. So we can check that later on. And the second standard is like the provision of care, the things that are provided to those patients who are coming with the neck or femur fracture, obviously. There are certain things that should be provided at the earliest point of contact. The moment the doctor in the emergency department suspects that the patient has come with a neck or femur fracture, so without having any delay, certain things should be given. So these are categorized as big six. Obviously, there are 6 things which should be given or which should be taken. They are a combination of giving and taking from the patient. So these things should be given or provided as an essential part of care to all those patients who come with a neck or femur fracture. Let me just give a brief idea about how you diagnose neck or femur fracture clinically and in the hospital. Well, an elderly patient, first important, we need to fill in small gaps in the presentation of when the patient comes to the hospital. First thing, elderly patient plus 60s, okay. Second thing, maybe 1 or 2 comorbidities. A third thing, patient is not able to walk. Patient, either he or she is not able to bear weight on maybe right hip or left hip. And it is the side on which he's usually having a fall. Maybe if he or she has fallen on the right side, she will be having pain. She will be having an inability to bear weight. She will not be able to walk on that side. And most important thing is that the side which is affected, either it's right or left, that leg will be short as compared to the normal leg. It will be short, first thing. It will be externally rotated. For example, this is the normal joint. It will be externally rotated. Leg will be like this. So if we consider this is the feet, normal feet may be like this. So in the case of neck or femur fracture, the feet will be like this, outside, stretched outside. So external rotation, the leg will be short, inability to bear weight. Those are the things enough to diagnose clinically that it's a patient with neck or femur fracture. All right. So I was talking about big 6. These are the essential. It's a small package of care that all patients should be provided if you even suspect neck or femur fracture. So simple things. Once there will be fracture, there will be pain. So you have to give painkiller. It depends upon the severity of pain. You will start with paracetamol. If the patients are okay, fine. If they still have moderate pain, you can go with tramadol or codeine or anything else. If they have severe pain, you go with morphine. Simple. The second thing about big 6 is like screening of delirium. Those patients, they might be elderly. As I was mentioning, they will have dementia. They will have other electrolyte imbalances. So you'll check the level of consciousness. You'll check whether they are delirium or not. So there's a scale. It's very simple, and it hardly takes 2 minutes in the emergency department to make sure that the patient is not having any kind of delirium or dementia or any other electrolyte imbalances. So it's called 10 AMT score. I can at the end I can share it's a simple questionnaire of 10 questions. You ask those 10 questions to the patient, and with each correct answer you tick 1 1 1. So 10 out of 10 means that the patient has enough of cerebral functions. She or he is not delirious. And as the score decreases, the probability of delirium increases. Third one is early warning scores. It's nothing new, it's nothing special. Early warning score increases like a couple of vitals. Maybe it includes temperature first thing. Second thing, it includes blood pressure. Third thing, saturation, oxygen. Fourth thing will check for hydration. Blood pressure is also there. So all those vitals, they include, we just score accordingly if everything is fine within the limits. So EW score will be 0. And with each levels of derangement in any of the aspect of vitals, the EWS score will increase. So just simple example, if the EWS score is like 6 or 8, patient, we might lose the patient. So we need to make prompt change. We might need to transfuse bloods, transfuse IV fluids, give enough of analgesia, check for saturation, give oxygen. So it's a good score, which gives a rough idea like patient is deteriorating, or we might need to make some prompt change at that point to make sure we don't lose the patient. Okay, it's simple. So we just check the vitals. If they are fine, EW score is 0, or simply we talk it as like national early warning score. So it sounds like news. So yeah, news. Fourth is when the patient comes to hospital in the emergency department, you take bloods, you go for full blood count, urea electrolytes, clotting times, any other scoring, any other things you want to do tests, you go with that. And at the same time, you go with the ECG. Fifth, I was talking about giving intravenous fluids. And sixth, you check for pressure area care. Those patients, those people, they're elderly. They might not be getting enough of care at home, or even the people who are living in care homes. So all those people, they might be neglected. So you check for the pressure areas. So big 6 is done. Um, if you try to give big 6 to all the patients who are coming in contact to you or to any other colleague in the emergency department, so half job is done. Like we're not letting the patient go, or we're not losing the patient at all if we try to make sure that this thing is provided in a patient with neck of femur fracture. So the goals, as I was mentioning, of this research, nothing new. It's just the same thing. So we did the research, and we just make sure that those group of patients, they are having giving the enough and good care at the emergency department, whether they are being transferred at the earliest within 4 hours from emergency department to orthopedics, and whether the big 6 is provided in time or not in the emergency department. So as I was mentioning, we have done 2 researches in 2 intervals of time. One was in May to June, July. That was one cycle, and another cycle was from September to November. So we are comparing those 2 bubbles all together and see, is there any improvement in the care that has been provided, or is there any deterioration? Well, we're being honest. I'm not saying like I was a new doctor here, I tried to do something special. Being honest, the honesty is a very important thing in working in particular medical field. If you do a mistake, you admit it. And if there's any deterioration in the services that you provide, you admit it and work on it. So why I say this, because there's deterioration. Let's see in the further slides. Okay, sorry. A quick idea I would like to give before we start comparing the data and how the care has changed over the period of time. I would like to give a simple idea how neck of femur fracture patients are transferred or trafficked from the emergency department to orthopedics ward. Like first step first would be patient comes to A&E, and the doctor in A&E suspects that the patient has neck of femur fracture. At the same time, they might bleep the orthopedics doctor or their assistants, which are called TNPs, that are called traumatic nurse practitioners. So like it's a special kind of class in UK. So these are the nurses who have like extensive experience in a particular field. For example, if a nurse has, he or she, the nurse, have been working in a trauma orthopedics department for like 12 years, 15 years, They are upgraded as TNPs. So these are special nurses who have extensive knowledge about fractures, reduction, plastering, and basic things. So TNPs will be informed, and well, they have extensive knowledge, 12, 15 years of experience in the trauma orthopedics. So they go and check the patient in the emergency department. They will check, do a simple survey or check the patient and see whether it is a neck or femur fracture or not. So two things can happen from here, from the step 2. Either it is a patient which is actually having the neck or femur fracture, so it will be taken care by our team, trauma orthopedics department, or it cannot be a neck or femur fracture. So they just assess, document that this is not a neck or femur fracture, and the reason, because I did this test, I checked the patient, it doesn't look like a neck or femur fracture. Or they also have to do investigations if they suspect and make sure it's not. So they refer the patient back to A&E doctors, handing over that it doesn't seem to be a neck or femur fracture. I have documented, I have put my name inside, and doctor then countersigns, the trauma orthopedics doctor countersigns, he checks, and we do it. And if the patient has neck or femur fracture, we clocking is simple, just taking the details, taking history, collateral history from the patient's relatives, calling GP who has been giving medicines to them. Second thing is marking. Marking is nothing, it's just a black marker. It's like a permanent marker. You put a big arrow on the limb on the side that's affected, right? Neck or femur fracture, you go with the marking on the right side. If it's left, you make a big arrow so that the limb is not missed. Obviously, there has been mistakes where there was a fracture on the right side and surgeon operated on the left side. So things can happen. And one important thing, the consent, which is not taken that seriously back in India, but here you have to explain all the procedures to the patients, give them choices. Like, we have many choices. We can treat you conservatively, we can treat you operatively. In operation, there are 2 or 3 ways we can operate you. There are prostheses, artificials, there are, depending upon the material, you have to explain everything to the patient. And at the end, it's the choice of patient, whether he wants to get this option, he wants to get that prosthesis. And once he is fully okay with all the things that we are going to do for the patients, we make them to sign a consent form in which everything is written clearly. And then the patient is shifted to ward, and from the ward, initial resuscitation, and then to theaters, and surgery is done. So, as I was saying, that we have 100 patients. We took in the 2 time intervals, one bubble in the early in this year, and second bubble in the late of this year, and we collect data as it was retrospective research. We need to go back in time and get the data, whether they have been given big sixes, analgesia, and other things, whether they were transferred from A&E to orthopedics department in time. So we have to go through the notes. All the notes are available. They are in the stores, and in here our system is like electronic. So many of the details are available online at the hospital's website. So, but obviously that's confidential. Anyone cannot check it. Yeah, only doctors who have the access, or the nurses who have the access, can check it. So keeping the confidentiality of the patients at the peak level, we did the research and checked how quickly it was done, how efficiently it was done. So, well, you can see I have made a histogram presentation of the 2 cycles that we have done so far. So blue is the cycle 1, which was done in the initial time periods of this year. And after doing that research in the initial time period, certain changes were made. We did some small presentations in the A&E department, educated those doctors in the A&E department, make them understand. Obviously, they are doctors, they know the essence of neck or femur fracture, but still, sometimes it's a good thing to give a gentle reminder, like how important things are and how they can be improved with bit of more responsibility. Well, we never blame people. We never blame our colleagues, whether it's A&E or surgeon or someone else. It's just the friendly banter and the gentle reminders for each other that how we can improve the quality of care for the patients. At the end of the day, all the doctors, nurses, all the staff members in the hospital, we work for patient, nothing else. There's nothing else we do there. Just we work for the patients. So yeah, but still, as you can see, the blue one shows the cycle first, and the green one is the cycle second that we did recently. So within 4 hours, you can see the guideline, British guideline, simply tells you within 4 hours the patient should be referred from A&E to ward. So in first cycle, almost 30 patients out of 50 were transferred immediately within 4 hours from A&E to orthopedics department. But in the recent one, you can see only, I think, 14 patients were transferred from A&E to orthopedics ward, even after giving gentle reminders, putting some posters in the A&E and all those efforts. But still, it's not even improved. It has decreased by almost like 50%. So yeah, there is something which is actually causing the problem. It's not A&E people, it's not the doctors are irresponsible, or it's not that they don't want to work or they don't want to help patients. There are a lot of other factors that we are still taking into consideration how the things can be improved. There's no blame game. There's no like the condescending things that we can do for our colleagues. They must be overworked. They must be understaffed. All those things that can affect the quality of care. The purpose of the research is to improve the quality, nothing else. And the research is done just to improve the quality we provide to the patients. At the same time, keeping our colleagues in confident that it's not something that we try to pull them down. That's all. So next slide, as I was mentioning, the first slide was transferring the patient from A&E to orthopedics department within 4 hours. So there was decrease, there is deterioration in the services without blaming anyone. But yeah, there are some things that we can do. There are certain things that A&E doctors, nurses, and other people can do to improve the quality of care. That's all it matters. And at the end of the slideshow, I will also talk about how we can improve such things. So that's another subject, but let's stick to this one for now. And then we have Big Six. The second standard, our second standard was Big Six. So as you can see, the blue one is the first one, and the second one is the green one that the research we did recently. So if you see the comparison, all the things that should have been given, there is decrease. There's decrease in taking the bloods, giving analgesia, new scoring, IV fluids, fib, chest x-ray, all those things have deteriorated. So we got an idea, a simple idea, that there is a deterioration in the service that should have been provided even after giving gentle reminders or making certain change in the first cycle of the research. The quality and the percentage of the care has not improved. On the other hand, it has worsened, it has decreased. So, and these are the like small presentations of what we call as the comparison, like how early the patient was referred to from A&E to the orthopedics nurse and doctors. So obviously there has been a decrease in overall time taking from A&E to transference to traumatic nurse practitioners. So overall, I can see that there's nothing good at all. There has been a decrease, downfall trend in all the services that should have been provided in time. Another one, time taken by review. This is for something. This is something which I could have done in time. I'm a trauma orthopedics doctor. I could have just gone there quickly and checked out everything. Sorry for that. But still, there is something that's still lagging. In the first cycle, out of 50, 40 patients were seen within 30 minutes of the bleep. Like you get a bleep, there's a patient, no. So you quickly rush to there and check the patient and take him. But now in the recent times, only I think 2 or 3 patients have been seen within 30 minutes. Well, I wouldn't say I'm lazy or my colleagues are lazy in trauma orthopedics department. But obviously, as I was saying, overworked. Sometimes you at the same time will have 3 or 4 more patients who must be waiting there, who must be having serious under conditions, maybe a trauma, maybe an accident, maybe a chopped limb, active bleeding. So all those things, they come first, and sometimes you cannot prioritize which is important, which should be taken care at the same time. All those things can matter. So the discussion is simple. If we talk about the summary of all the presentation, in the standard one, that from the time of presentation to the A&E, to the transference, to the orthopedics ward, there has been a decrease. There has been almost 30% decrease in taking the patient from the A&E to orthopedics. Simple. Standard 2 also, there's decrease, there's downfall, there's deterioration of providing the care at the base level. That's A&E, the big 6 as I was talking about. So, well, it's not always just enough to point fingers like you are not doing this. What we can do is like we can educate those people in the emergency department, and we can also educate in our department the doctors, the nurses as well, to make sure that once you get bleep for neck or femur fracture patients, just go quickly and grab the patient. And sometimes you can prove a helping hand. If the emergency department, they have like a lot of patients, me as a doctor can help them, or our nurses who are going to take the patient, they can help them and make things easier for everyone. So it's not always just you do your part and I will do mine, but we can collectively work together and make things simpler for everyone. So those things. And second thing is like documentation is always important. Whenever you do something, you always document in UK. Like I might have missed once or twice, but that comes to me as a big sin before I go to sleep. Even if you do small thing, even if you just prescribe a simple tablet, or you make simple change, like the patient should be restricted as the fluid should be restricted to maybe 1.5 liters. You tell the nurse did it actually, but you forgot to mention it in the notes, or even in the care flow, which is like online notes in our hospital. Well, everything should be documented. So whenever I remember anything, I quickly go to my cell phone, go to the online notes and put the notes in the patient's name. So obviously the documentation can be improved, and all those things can be done, like making sure that everything's quick. I think that's it. That's enough of it. And obviously encouraging patients and the staff members to help each other. That's pretty much it. So that was the presentation. Thank you so much, guys, and hope there will be questions. So we'll be taking questions.
Hello. Yeah. Thank you, Dr. Yasir. That was really amazing. It gave us a lot of insight into what fracture femur really is, and the big 6 and everything. That was really informative. Now we have some questions that we would like to ask you. Me and Insha will be asking you some questions.
Yeah, sure.
So one of the questions that I wanted to ask is, why is it so important to send the patient immediately to the from the ward or from the A&E directly to the theater? Like, why is that time frame so important, that getting that patient from A to B?
Yeah, it's very important. Like as I was mentioning, that British Association of Orthopedics, BAO, so they have been doing research over the past couple of decades, and they have seen that the neck or femur fracture is very delicate, in the sense that first thing is very important, weight-bearing fracture. If we delay the treatment, if we delay the transference of patient from A&E to orthopedics ward, that can result in long-standing decrease in the quality of life. The joint may not heal properly. The joint will have some malunion, some non-unions, or even the avascular necrosis of the neck, AVN. So all those things, even though the patient lives maybe after 60 years or 70 years, they still live for 10 or 12 or 20 more years, or no matter, like even they live for 40 more years. The quality of life, it decreases. Like what's the life worth of if you have been walking, jumping for your 60 years, and suddenly one day, because of a simple fall, you are just frame ridden, or you're just using crutches for the rest of your life. So it has a dramatic uh, impression on the patient. So the things have been seen that if we try to make sure the patient gets care transferred without losing time and getting treated, the operation itself should be done within 72 hours. So on basis on those things, so these things give the best outcome for the patient. They may be able to walk again, which is happening. Like 90 to 95% patients after the surgery, within time frame, they walk again. They have the independent life. They get the leg back. So that's why it's important. It's based on the research. It's not some couple of doctors they came together and say, let's take it for 4 hours. No, it has a clinical essence behind it. Okay, so the 4 hours is the best thing to make sure that there's no loss of blood, there's no comorbidities associated with it, or late long on consequences of the neck or femur fracture. So 4 hours is the best way to make sure that we don't get out of the line, which will have some deep impact on the health of the patients. Okay.
Yes, sir, may I please remind you to turn off your screen sharing, if you could do that. Okay.
Oh, yeah, sure. Thank you
Thank you.
again. Anyway.
Thank you. So
Right.
another question that we would that had came through was that you told us about the Super Six, like that they're really important to follow and stuff.
Yep.
But what's the actual like essence? What's the actual significance of like following these Super Six in the treatment?
Well, Super 6 is it's nothing new. It's actually a national early warning scores, which is not even essential for the patient which comes with the nerve fracture. It's usually done for all the patients. Like even in India, I don't know whether we are associated with new scoring or not, but even if a patient comes to the emergency department or to the ward, or he or she is deteriorating in the ward, I think the best thing one can do, even the nurse or even the junior doctor can do, is just quickly check the saturation, check the vital, check blood pressure, pulse, heart rate. So it's something which is checking the vitals and making sure that like ABCD is fine. So it's essential, and small bit tailoring of the ABCD and the basic approach primary survey, and tailoring it in such a way that it gives more input about the neck or femur fracture effect on the body, on the health. So that comes out in the form of EWS scoring. So it will take care at the same time like vitals, which are very important to make sure ABCD is intact, and at the same time gives information about like there's no deterioration of the patient with neck or femur fracture. It's not exclusive. It's not like exclusively for the patients with nerve fracture. You can do it for anyone, any patient, anywhere.
Okay, so basically it's like the best quick assessment that you could do, like,
Yeah.
to understand.
Yeah, it's a sort of like primary survey that can be done very quickly.
Right, exactly.
Okay. So what is the vulnerable age group for the injury of the neck of the femur, the age group?
Yes, definitely. There are like as I was telling, the neck or femur fracture is something which is very important, and in elderly patients. So the patients who are like plus 60s, they're the people like who are susceptible to neck or femur fracture. The reason being is that obviously elderly people, they don't get enough of calcium supplements. Their bones start losing calcium and the mineral density decreases. Osteoporosis is quite common, and the people who are living in like subtropical or maybe temperate zones, they don't get enough of sunshine, so there's decrease in the vitamin D supplement. um, Staying indoor, all those people like elderly people, they don't go out much for a walk in sunshine or sunbathing or anything. So osteoporosis, osteomalacia, they can coexist, and plus decrease in mobility, inactivity, increased weight, all those things. I think those comorbidities are usually quite common in the elderly population, and elderly population is the most vulnerable group of people who gets enough of no fracture. Young people like us can also have the neck of femur fracture, which is quite traumatic, which is usually seen in cases of like severe road traffic accidents, falls. So all those things. Yeah, it's not uncommon. I wouldn't say that it is very uncommon in young population. I recently saw a 26-year-old guy. He was riding a bike and he had a fall on right side. A very clean cut. Luckily, his rest of the body was fine, but very clean cut neck of femur fracture on right side. It was something different. Yeah, something new to see, like a young guy coming with neck of femur fracture.
Okay, so basically, like in the younger age group, it's quite the traumatic road traffic accidents,
Yes.
and in the older age group, it's like a slow onset of, all these
Osteoporosis
demineralizations
and
of the
the
bone.
bone change and everything that can result in neck of femur fracture.
And sir, how is it exactly healed? The neck of the femur, how is it healed?
Oh, like any other fracture, it heals if we try to make sure that the opposing parts, the fractured sides, come in contact with each other, stay in contact with each other, and well, it's a weight-bearing joint, so it has more responsibilities to bear the weight of the body. And if the opposing surfaces don't stay in line, there will be like malunion, non-union. So all those things we need to make sure that they are in contact. Well, you can only expect a union only when the opposing surfaces are in contact with each other and with good amount of pressure. So there are many ways we can treat a neck of femur fracture. Surgeries are done, and surgeries we usually try to make sure that either if it's a young patient who has very good bone density, we try to fix screws, cannulated screws. We put like, it's simple, like drilling. You drill it from this side and put a long screw that goes from this fractured bone to this one. We usually put three, 1, 2, 3, medial, superior, and the lateral one, and that's how they stay together. And the opposing sides stay together and they heal.
One other thing, so like now, like after this person has had a surgery, has had all these screws put in, what is the quality of life thereafter? Like, how long does it take for them to heal? How long does it take for them to again bear weight on that joint? Like, what is the quality of life thereafter, basically?
Yeah, it's very important. Well, post-op day 1, first day after surgery, the patient with neck of femur fracture, either if they undergo like cannulated screws, or if the bone quality wasn't good and we took off the neck of the femur and replaced it by prosthesis, and at the same time we changed the acetabulum of the hip bone. So like that's called a hemiato. This is called total hip replacement, in which we change the neck of femur as well as the acetabulum. It's called total hip replacement. If we change the neck of femur only, that's called hemiatoplasty. If we put the screws, so they are called screws. So basically the thing is, post-op day 1, irrespective of what kind of surgery you have undergone, the post-op day 1, the patient are supposed to walk with full weight bearing. Okay, it's the day 1.
Day 1, like from
Yes,
day 1,
day 1.
you just start walking.
Yes,
Okay.
they have to walk with full weight bearing, irrespective of what kind of surgery. It's hemiatoplasty, it's total hip replacement, it's cannulated screwing, it's dynamic hip screw, many other things. But the day 1, the patient are supposed to walk with full weight bearing, and that's usually done with the help of physiotherapists. So physiotherapists, they come with the frames to make sure that they don't fall on the sides. The patient also think that they just had a surgery and they have broken the hip bone, but it's like something weird, they have to walk. But yes, it's always day 1, they have to walk.
Okay, all right. That's really interesting. Inchi, there was a question from the comments. Do you want to take that?
Yeah, there was a question, what are the clinical presentations? for the neck of the femur in A and E, sir?
Yeah, simple clinical diagnosis of A&E. Patient is in pain. She's holding her hip, maybe right or left. We just have two hips, so yeah, two sides. And patient is, she might, if she's old and her pain tolerance can be low because of the neurological problems, decrease in the neurovascular efficiency. So she might not be that much in pain, but she will not be able to bear weight because the hip bone is broken.
Yeah.
So inability to bear weight. Definitely the limb will be shorter than the normal limb. The leg, if it's right, it will be 2 or 3 centimeters less than the normal leg, and it will be externally rotated. We just,
Okay.
let's assume the patient lies on the bed and these are her feet, okay?
Uh-huh.
If she has a fracture in this one, this is normal feet. The normal feet will be like this, and the fractured one will be like this.
Okay. So you could like literally go to the head of the bed and see that the foot just turned to the side.
So this is called external rotation. The limb will be shorter. Patient will be unable to bear weight on it. There will be pain. So enough. That's enough for me to take the patient. Okay, neck of femur fracture.
This was really nice to know
It was
the
really nice just looking at the feet. Exactly.
That was really great.
Yeah.
Also, sir, you just mentioned like day one. Like I'm really surprised by your point that the patient is asked to walk with full bearing since day one. Why is that? Like all our years, like we've seen like take a bed rest and then they're probably like how this change in the treatment came into.
Well, it's very important question, very good question. Like even the patient just ask us, like, we just had a surgery and
Yeah,
why,
exactly.
and my bone has broken, and the part of my, maybe sometimes 𝗵�々𝗶𝗶 or total hip replacement, they would say like a part of bone has been taken out. Why should I
Yeah.
walk? The thing is, there are 2 or 3 things which are very important in this aspect. There are the countless things. The first thing is that the earlier mobilization gives you a rough estimation about how good the fractured part is fixated, okay? The screws have enough of the strength to bear the weight altogether. The bone is just broken. It's just a fracture line which has just separated the bone. And the screws or the uh, prosthesis, they are enough to take care of all the body weight on that side. So a patient who has either got cannulated screws or 𝗵�々𝗶𝗶 or total hip replacement or any other modality is enough to bear the weight on that side. There can be some discomfort, there can be some tightness, there can be some any other sensation, but it's definitely not going to cause any other fracture or any other problem. There can be sometimes pain as well because of the increase in the pressure of the compartment. But early mobilization is important because it makes your hip work, the muscles around those screws and the fracture site. They gets more strength. It's more of like using the muscles to get in place around the capsule and getting more strength at the earliest point, so that the prosthesis, the screws, whatsoever we have done, will get more quickly absorbed in the body or more quickly adjusted in the body. The second important thing is early mobilization is important because we don't want our patients to get pulmonary embolism or deep vein thrombosis. It's leg. And if a simple patient comes with a leg fracture or with a hip fracture, they won't even move their leg at all. And a leg lying down on the bed for 48, 36 hours, 72 hours will definitely have DVT and pulmonary embolism. We have so many patients with coming with then pulmonary embolism and all those problems, and we don't want that happen at all. So early mobilization, make them walk, calf muscles will squeeze, DVT will be relieved, and we don't want DVT at all.
In these patients, so do you give them like prophylaxis, like low molecular but heparin prophylaxis or something like that, just to prevent?
Any patient who comes in the wards, in the orthopedics ward, coming with any problems, any joint problems, any bone problems, which may compromise his mobility to some extent, they may be able to walk. The full weight bearing is there, but it's not as good or efficient as a normal walk of the person. It is restricted, it's aided, it's under the supervision of physiotherapists, doctors. So we make sure that the patient's mobility has decreased, so blood should stay thin. We give low molecular weight heparin, enoxaparin, subcutaneously to almost all the patients who come in ward, and they sit on the bed or stay in the ward. All those patients are given enoxaparin to make sure we don't have DVT, that DVT prophylaxis.
All right, that's great. From the YouTube comments, we had a few questions. One of the questions was, with newer advancements, how efficient can management be? Like, what are the newer like sort of advancements to treat this sort of, fracture of neck of femur? Like,
Yeah, there has been the constant researches are undergoing to make sure that the treatment is effective. The new prosthesis, actually, the prosthesis which are lightweighted, which are easily available, they should be becoming more common in the surgical departments. And arthroscopies, like it's not always, so we try to cut open the leg on the lateral side and make sure we go with the total hip replacement or other things, or even screwing, the canalytic screwing and other things. There are other things like arthroscopies, which are done with small probes, robotic surgeries, which are done by the robotic arms to make the precision almost 100% accurate in placing the screws, reduction of the fractures. So those are things which are still under trial, but many of the hospitals like Oxford Hospital, they have started using the robotic surgeries, even in the treatment of neck or femur fractures, to give 100% precision in the reduction of the fractured sites. Arthroscopies are done to make sure if it's not that much displaced or it's not a bigger fracture, it can be treated with arthroscopies. So yes, definitely.
I've always heard of this orthoscopy, and like we've read about it in our ortho books, but like to be actually done and to actually see that's really amazing. Like, to like minimally invasive.
It's just like laparoscopy of the joint.
Exactly. It's really nice to see the new advancements like that actually being applied. Yeah.
So those are done, particularly arthroscopies are done for the knee joints, knee problems, like meniscal tears and other things. Meniscal tears or the ligamental tear, like anterior cruciate ligaments, medial cruciate, lateral cruciate ligaments. So those cruciate ligaments and the collateral lateral ligaments and the meniscal tears, they are usually nowadays in here treated with arthroscopy, not with the open surgeries.
Okay, that's really nice being part of that, those amazing surgeries. And so there was one other. Yes, Insha, go ahead.
I was saying these are great advancements in medical science.
Yeah, they really are. They really are.
Yeah, definitely. It is like very good to see like small holes doing the best job, other than opening the joint up.
Yeah. There's another question from the YouTube comments, and it was that despite from plenty of hours of sun exposure, vitamin D still stands as one of the top causes for osteoporosis and other pathologies. What is your opinion?
Yeah, that's true. Because I worked in India for almost 1 year, and many of the patients will come with body aches, back pain, lower back pain. Young patients like our age of group, elderly, they were always coming with the back pain, muscle aches. Even India, like we get temperature of 46, 47 degrees of temperature. I was shocked. The vitamin D levels would be like 4. The normal range is up to 30. 30 is the lower limit and 100 is the upper limit. International units, IU international units. 30 to 100 is the normal range. And my patient would be having a range of like levels of 4, 3, some people with like undetectable vitamin D levels.
Oh my
So it's
goodness.
surprising.
Okay.
Yes,
Yeah,
it's really surprising to see like our country, India, is like so hot. It's still patients lacking vitamin D. And it was with everyone. I haven't seen a single patient who wasn't on supplements and who was having normal vitamin D levels. Even myself, I was having a level of 12.
Okay.
So the thing is, the only thing, I think this is very weird. that I made up in my mind is that we confuse hotness with sunlight. Actually, we feel it's hot, it's warm, even it's like humid, it's warm. That's not the sunlight. Actually, sunlight is the actual exposure to sun.
Yeah,
So
and
saying
we
the
avoid this.
temperature is high even in your room doesn't make doesn't mean that you are actually exposed to sun.
Wow, that's amazing. Seriously, because like when it's really hot and humid, we avoid the sun a lot. Like we close the
Yeah.
curtain, everything. Yeah, really, really.
Also,
So
sir,
for all those
I
people,
had read an article
yeah,
like a
Insha.
no, you go ahead, then I'll ask.
No, you tell me. I will tell it later. Please
No,
go
sir,
ahead.
in like time I had read an article and it said like the duration of the sun bath or the when we try and expose ourselves to the sunlight, it should be from 8 a.m. to 10 a.m. something like that. Is that the time like, or
No,
is it
that's totally no, that's totally wrong. From
okay?
11 from
Okay.
11 a.m. till 2 p.m. That's the best overhead sunlight. That's the best
Okay.
beneficial sunlight for the body. Okay.
Yeah, right. Okay.
And exposure, at least
Mm,
every day, half an hour exposure.
mm,
Uh, hold on, 15, 5. Yes, the best portion will be like having from 11 a.m. till 2 p.m. when the
yeah.
sun is overhead
Yeah.
exposure.
We
And the
avoid.
best one, if it's possible, half an hour exposure in the sunlight. You can be in bits like early in the morning, by 11, you go out for 5 minutes, stay there in the sunlight, go back to your work, whatever you're doing. By 12, come back again for a small walk, expose yourself again for 5 minutes. So till 2 p.m. That's the best thing. See, I'm not excluding the early morning sunshine or sunlight. It will
Yeah.
help definitely. But if you
Yeah.
talk about best, so that's the 11 a.m. in the morning till 2 p.m. That sunlight, overhead sunlight, has the most good intensity, ultraviolet radiations,
Yeah.
production of called calciferol by 12525, and other things in the body.
Mm,
That's most beneficial. Half an hour should be the target, but it may not be achievable every day, but that should be the target. What you can do, go out for 5 minutes, roll up your sleeves, okay, like
okay.
this, roll up your pants a bit, lay down, your face is also exposed to it,
Mm,
and that's all. For 5 minutes, go back to work.
okay.
Yeah. Um,
Yeah. And
is
if
it
you are in privacy, then you can like expose as much as possible. That's up to the privacy of the people.
yeah, that's very true. Um, but like for example in India, isn't the sun a little too harsh at noon, or is that okay? Like that, 5 minutes won't make a difference.
I think, well, if you talk about tone getting black or other things, I don't know about that. But yeah, 5 minutes won't cause any problem. Like, I don't think 5 minutes are going to cause any problem. 5 minutes
Yeah,
for at one
True.
time.
Yeah.
yeah,
Right.
hopefully. Yeah,
Well, you
we'll
have to
reduce.
set the like thermostat on yourself. I'm sure, like even if the temperature was 46, 47 degrees, you must have taken a walk in once in a while, and it was worth it. So, and second important thing, see, the sun. We don't have to eat sun for vitamin D. We can take vitamin D supplements, isn't?
Yeah, that's also very true.
Yeah.
We can supplement
So
ourselves.
there are supplements available in the market. I will tell you the regime. Vitamin D capsules are available in the market. They come in the form of 60,000 international units. 60,000 international units. 60,000 international units. You go with one capsule once a week. Okay, one
Yeah.
capsule once a week, and you take this capsule for 6 weeks. Okay, so all you have to get is 6 to 8 capsules. Would be the 8 capsules would be the best thing. Take 8 capsules in 8 weeks, and I think that will take care of the whole year. And next year you do it again. Okay,
Okay, so
Okay.
you just build up your reserves in that 6 weeks, and you're
eight
good
weeks.
to
I would
go.
say go with 8 weeks. That will take care of
Mhm,
all the deficiencies in the body for one year.
mhm. All right. And
And
okay,
if you want
so
to know, like there are companies like Uprise, Nickel, all those people, they sell very good quality of vitamin D3. Uprise is one of the good things I would suggest. I think Cipla, so whatever. But yeah, 8 capsules in 8 weeks, 1 capsule early in the morning before breakfast with a glass of milk would be good because it's a
Okay.
vitamin D, it's a fat soluble, so milk will be good.
Yeah, all right. Okay, so we're coming to the end of this webinar, but like a lot of people wanted to know like how did you reach, what was your journey basically from doing your MBBS from India to the UK, the favorite pet top question.
Well, I would say I don't want to be like rude or condescending. Being in India, I learned in a hard way. I learned how hardworking a person should be. I did the basic gymming and building of muscles in India, though even though I'm Catholic. But the thing is, we Indians are really hardworking. We can make things work. We can just have sleepless nights, back aching days, maybe head full of like throbbing headaches, but we still make things work. Okay, so all you guys who aim to get better in medical system, who have their dreams to go abroad, get good and new and better trainings, I would say it's possible. It's very easy and simpler because we are Indians, we are hardworking. Okay, simple thing as that.
Wonderful.
Yeah,
Yeah,
that's very inspirational.
and
Yeah.
once you come out of the system, it's not we doctors, or it's not the medical system which is actually weak in India. It's, I think, there are multiple factors like corruption at the different levels. Let's not go there, but it's not the deficiency of the doctors or the knowledge of doctors that makes our system, not that good or not that great. I wouldn't say our doctors, they are not hardworking. We work like 36 hours back to back in A&E. I've seen my colleagues working like forgetting their home for 1 year and just living in hospital, doing like day night day shifts all together. That that takes some energy, and that takes something out of you. So we wouldn't say that we are not having enough of knowledge. We literally cram up all those big books like Harrison, Davidson, Tripathi, and all those
Yeah,
physiology, Ganam, and everything.
yeah.
People in here, they don't study that much. But the thing is that their system, the funding in the system is so good. Everything is so efficient. Everything is placed in line. Everything is so clean and good that they don't have to do much. Everything is there available for them. All they have to do is just type, click, 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 hyperkalemia treatment. Everything comes in line, one, 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 one. They don't have to go for the books and everything and read everything. So everything is available. Everything is so well maintained that makes the system altogether better. It's not this. It's not us, the doctors, or it's not the people working in the healthcare system in India that makes it less good. It's overall the system, all the factors, financial, the legalities, the rule following, the people itself. So these things collectively matter a lot. So everything is possible. The journey was so good. I've been from a very hardworking background. My colleagues, my friends, my family, uh, they recognize that I'm a bit hardworking. I'm lazy now. So, but yeah, um, coming here, it's not a big deal. It's not a big shot. Anyone can make it. I'm sure, like, if you all guys will try to take it, the exam and everything, it's not a big deal. You all will make it and you get good jobs in here and go for the bigger trainings and have a fantastic career in later on. So yes, it's not a big deal. You can do it. Okay.
So what like made you go like towards orthopedics? Like, what was your passion? Like, why, do you want
Yeah.
to do orthopedics?
Oh well, I was always interested in like blood suturing, and it gives you something. And then so emergency cases, like running to the emergency department, making some heroic moves, and yeah. So all those movies, like you see the people running, rushing to the like bays or to the ambulances and taking care of the patients, and the team of doctors taking in the trolley. which rarely happens in India, but yeah, it's like a routine day here. So yeah, it's like a sort of movie thing, like, you know, you being a part of the movie, being the hero. Yeah, that was the
Alright.
motivation. That's all. That's all I can say.
Okay. All right. I'm really thankful, sir, that you could make the time and the effort and everything to come and to like give us a more in-depth of the fracture of the femur and some really nice life advice as well, because like some of us, especially like we're all like quite in that phase where we don't know what to do in life and
You
how to,
definitely know. Don't worry
yeah,
about it.
proceed
I will
through
be
it.
always
Yeah.
there for all you guys, all the viewers who are watching this or who might watch it in the later phase. Uh, Please feel free to contact me. I'm always here for all you guys to help as much as I can, as much as time I have. I'm always here to help you. Okay. And
Okay.
I'm
Thank you
really
so much.
thankful to Lina, to Pooja, Insha, Dina for organizing such a lovely webinar. I loved it so much. It's really interesting. I would love to do more in future.
Yeah, we would love to have you as well. And both me, Insha, Pooja, and Dina, we're really thankful that you could really make the time for us. All right,
Yeah.
so any last questions or anything? Any more last questions, anybody? All right. Okay. All right then,
Just,
thank you.
I'll just mention this, that there is going to be a post webinar on the feedback form in the comments section. Please go ahead and fill it, and I hope
Mhm.
you guys liked it.
Yeah, okay. Thank you
Yeah.
very much, everybody. Thank you to SIMSA. Thank you to Dr. Yasser. Thank you to Insha and all the other organizers behind the scenes. Pooja, especially a special thanks to Pooja allowing us again and again to
Every other.
hold these exactly every other day hold these webinars. And thank you, Yasser, again. All right
Thank you so
then.
much, guys.
All right then. Okay, take care. Have a good day, everybody. Have a good Sunday. All right.
Yeah. Oh, I have to go to work.
Goodbye.